Hello viewers, welcome to one more edition of Mynahcare Positive Life series. Human emotions knows no bound, and especially when it's having a baby, we go out of the world. Today we have come to Dr. Abha Majumdar, Director and Head of IVF, Sir GangaRam Hospital, to know more about infertility and IVF. We would like to know from her the way forward for a lot of us. Over to Dr. Majumdar. Ma'am, thank you for your time. Today's day and age, infertility is on the rise. So are the technology related to the treatment of it. Today we are here to know from you, A, the various reasons for infertility and what we are doing to treat them.
Well, Mr. Joydeep, if we talk about the reasons for infertility, they have been the same since ages. We divide them into two broad groups, reasons belonging to the man and the reasons belonging to the woman. When we say reasons belonging to the man, they are generally defects in his seminal plasma, which is known as semen in layman's language. They could be deficiency of sperms in their numbers, in their movement, or in their size and shapes. So all these deficiencies do not let the sperm fertilize our egg and cause a pregnancy. On the other hand, in the woman, there could be two major factors which lead to infertility. One is lack of ovulation and two is some defect or blockage in its structure. If there is a blockage in the tube or in the uterine cavity, then this also doesn't let a pregnancy happen. So broadly, we would say it is either male factor or female factor, and in the woman it could be an ovulatory factor which could lead to infertility, or a tubal problem which could not let the sperm and egg meet.
Ma'am, through your experience in today's day and age, is there any lopsided contribution of male or female in terms of infertility and not being able to conceive?
Well, in fact, over the years, it appears that male infertility is on a rise only. We used to say that 20-25% of infertility is due to male factor. It appears now it's gone up to 30%. And in fact, now when we distribute the percentage of infertility, we say that out of all infertility cases, 25% is due to male factor, 25% due to tubal factor, another 20% due to ovulatory disturbances, and there is a segment of about 20% where it is unexplained reasons of infertility. Whereas there is a lot of overlap between two factors also. There could be purely male factor in 30%, and there could be a male factor where a female factor also coexists. So the total never becomes 100%.
Right, right. Ma'am, as far as the increase in the male factor that you pointed out, what could be the reason for this increase in the male factor?
It could be the environment which we are living in. It could be environmental pollution. It could be the fertilizers which are being used have possibly a lot of estrogens in them, and when these estrogens by way of plant go into our body, probably rise the phytoestrogens into a man's body as well as a woman's body. Man has a very delicate proportion between androgens and estrogens. The moment estrogens start rising, it could lead to a lot of problems in a man related to high estrogen levels. So does obesity does for a man also. If the man is obese, a lot of androgen is converted in his fat into estrogens. So these are one of those, because chemical fertilizers are being used today to grow more crop in the industry of crops. Two is, it could be mechanization of our lives, sitting jobs where a person is sitting for hours on end, and hence the testicular temperature could be a little higher as they are closer to the body. There could be possibly the use of computers, of cell phones might have an effect. It's not really known whether they have a real effect, but they all are attributed towards rising male infertility. I wouldn't say smoking as much, because there has been up and down in the incidence of smoking all throughout the world.
Right. Ma'am, as far as treatment is concerned, what are the latest happening in treatment?
Well, all the latest advancement in treatment, you see, all treatment for infertility can be divided into three broad groups. For anything, they're divided into two groups, medical and surgical. Whereas for infertility, there's a third group, which is assisted reproductive technology also. When medical and surgical don't find their way into treating a couple, then we go for assisted reproductive technology. So there is advancement in all the three.
Right.
If we say medical advancement, then there are newer drugs which are coming up every day. There are recombinant gonadotropins, long-acting gonadotropins, to make it easier for women to be able to go through all the treatment protocols. Then for men, there have been drugs which might improve their sperm count for cases where there are high estrogens. We give aromatase inhibitors to stop the conversion of androgen to estrogens to such men, especially very obese men, where we know that they can't lose weight on a click of a finger. But then at least we can depress their estrogen levels and make their sexual function better, make their sperm parameters better. This is medical side on one. Surgical side, laparoscope is doing a lot. Laser is helping us to do very good clearance of pelvis, where we find endometriosis, tubal factor infertility, intrauterine synechia. So surgically, we are trying to go on improving our surgical techniques to make the pelvis look more and more normal, or pelvic resurrection, in other words. It can be done near normal so that everything starts working again.
Right.
And then there is IVF. So all three have advancements. The maximum is happening on assisted reproductive technology side, where IVF is the mainstay. And in IVF, as ICSI came up, then preservation of gametes came up, oocyte preservation, embryo preservation. Then we came up with time-lapse technology to be able to identify the best growing embryo. Right. Then there are other methods also. We've started doing pre-implantation genetic screening of embryos to know genetically which is the best embryo, and then we implant these embryos into a woman so that her time to pregnancy is less. Right. Our main thing is to optimize a pregnancy rate. Right. We don't want a lot of attempts of pregnancy. We want that in lowest number of attempts we can create a pregnancy, and that also singleton pregnancy. Because again, twin and triplet pregnancy may give you 2-in-1 type of a thing in your head. Right. But for every twin born, we've lost 5 twins on the way. Oh, so that's a big loss, and therefore it looks very rosy. A lot of people come to me saying, can you give us twins? And I tell them, do you know, when you see 2 nice beautiful babies lying in that crib over there, 5 have lost their lives somewhere in between, and maybe some of them are lying in the nursery still trying to cope up with their mental neurological deficits. Right. So don't try to go for multiple gestation. Humans are not made for multiple gestation. We have been designed by nature to make a single child. If there are 2, we can cope, but we may not give the best baby out of that. So all this treatment is directed towards selecting the best embryo which can give rise to 1 singleton pregnancy, and the time to pregnancy has to be reduced. So this is our aim by adding up advancements in assisted reproductive technology.
Ma'am, before I ask you about explaining in brief about the procedure undertaken in IVF, I would like to know what are the probabilities and percentages related to IVF. I mean, if somebody goes for the procedure, what is the average?
In the best of centers, you wouldn't get a take-home baby rate of more than 35-40%. A pregnancy rate may be higher, even 45%. But when we say 45%, this is in good prognosis patients, where we have good number of eggs, age less than 37, for Indians maybe age less than 35. Then we say that yes, we can give a pregnancy rate of 40-45%. But then there are centers who have just come up and may not be able to give a 15% pregnancy rate. However, ironically, everyone says that they have a 40-45% pregnancy rate. And it is very exceptional to see Indian websites advertising on their website a 80-90% pregnancy rate also, which is unrealistic.
So our viewers need to be very cautious about what they read on the web.
What they read. Today only someone was saying that I read on the website, it's some sites say 80-90%. I said, was it a Indian website or from an Indian doctor or somebody abroad? They said Indian. I said, you go into other websites and you'll find the best centers in the world don't write a pregnancy rate more than 50%. And that also, when they write 50%, in a corner somewhere they would have written women less than 35, good prognosis patients, good ovarian reserves, good ovarian reserve. It's not patients who have poor ovarian reserve, off-age women. We cannot give a pregnancy rate of over 30%, 25%. And this is after striving for so long. In fact, we are going to have 25 years of IVF completed this year, and we are going to celebrate that. And I was looking into our pregnancy rates over the years. We started IVF way back in 91. In 96, the pregnancy rate was like say 18-19%, and we were quite happy at that. And that was 5 years gone of IVF. Today we've been able to say that yes, we consistently are keeping our pregnancy rates over 40%.
Right.
And that is when we are using all type of new technologies like pre-implantation genetic screening and blastocyst transfers, and growing up, freezing all embryos, doing 1 or 2 transfers only at a time, so that we can optimize, the number of stimulated cycles can be minimized.
Right.
So it is very important to know that pregnancy rates alone do not matter. It is a take-home baby rate which is very important. A lot of time we have a lot of pregnancies positive, and then a lot of them are shattered within the first 3 months. So it is important just not to see the positive beta HCG rate. And here I would bring your attention to one important thing, that there is an injection known as HCG, which is given to a lot of women during their, after IVF, during the luteal phase. And this injection could also result in a positive beta HCG or positive test in the blood. So beware that your patient has not taken a beta HCG injections 3 or 4 days before the blood test.
Right.
And they're very sad, but yes, again, this is true that a lot of centers do this, that they give a beta HCG 2 days before. Sometimes they write it, sometimes they don't even write the injection, it's just given at the center. You're called and you're given an injection.
Right.
And then a pregnancy test is undertaken. And it feels very rosy when all patients compare, oh, you're also positive, I'm also positive. And after a week, all of them have tumbled down.
Right. So you build hope and then it gets damaged.
Gets damaged. And this is not building hope, this is giving a false positive
Right,
pregnancy
right,
test.
right.
So there are so many flip sides of this treatment that it's so difficult for patients to gauge what is right and what is not right. It is impossible. So what I really feel is very important to do our work very earnestly, be very truthful to what we write, what we preach, and probably that is the only way to success, because if we keep boasting about high pregnancy rates and we don't have it, we will never be able to get better pregnancy rates. It is
Right.
only when we are lower than others that we strive to be like them or better than them.
Right, right. Ma'am, very interesting points, and in fact, I would discuss more of this in the later part of the interview. I would like to know at this point in time what, briefly, if you can tell me what entails the IVF process.
Well, IVF means in vitro fertilization. Normal fertilization happens in vivo, which means in vivo means inside the body, in vitro means outside the body. So fertilization means the combining of an egg with a sperm. So ordinarily it happens in our body in a woman's tube, a fallopian tube which is connected to the uterus on one side, and it is lying very close to the ovary on the other side. So an egg is sucked in by the tube from the ovary, it is traveling in the tube, and in the next say 16-18 hours is the life of the egg. If a sperm comes and fixes itself on this egg, penetrates it and gives it the remaining chromosomes which are lacking in the egg, and it makes a diploid
Right.
embryo, then it becomes it's called an embryo when the chromosome complement comes in 24 plus 24.
Right.
An embryo is formed, it travels in the tube for the next 5 days, reaches the uterus,
Right.
and implants there. It becomes a blastocyst, hatches and implants around 5th, 6th day of its life. So this is what happens in vivo. We mimic the same thing in vitro. We take out the eggs from the ovary, we combine it with the male partner's sperm. One sperm only attaches to one egg eventually, whatever we do, whether we do simple IVF where we keep an egg with sperms or we inject a sperm into the egg. Embryo forms, next day we look into it at 18 hours, we see that yes, 2 pronuclei have come out, which means that yes, an embryo has formed. And then these are let to grow, and day 2, day 3, day 4, day 5, day 6, these are the maximum days an embryo can stay outside the body. After that it needs blood supply to nourish it, and hence has to reach the mother's uterus so that it can get nutrients through the mother's blood
Right. Ma'am,
connection.
in today's day and age, what kind of preemptive measures does the doctor take to ensure that what has been implanted inside the woman's body actually grows and the probability of becoming mother is ensured?
There is nothing which can ensure the probability of motherhood. There is nothing. We don't have any way to say a embryo may look very beautiful. It may look absolutely healthy and yet it may not implant, because it is not the embryo alone, it is not the seed alone, it is the soil also which is responsible, and it is the interaction between the two.
Right.
You understand? So it is a crosstalk between an embryo and the endometrium, which is the soil, the lining of the uterus,
Right.
where this attaches, the blood vessels grow and supply the embryo all the nutrients and food which it requires. So all we do is we look that the rate of the growth of this embryo has been good, the embryo looks healthy. We could also do a pre-implantation genetic biopsy to see that genetically it is normal. This is the highest possibility we can ensure a normal embryo. And if we are putting in a normal, genetically normal, by looks it's normal, the growth rate has been normal. So these three methods are used mostly.
Right.
The morphological selection, the growth rate selection, which is also done by a machine which is known as time machine,
Right.
a time lapse.
Right.
And it is also done by biopsying and seeing that yes, chromosomally it is normal. So if we've got all this, then we ensure that the embryo is very healthy, it's grown up to day 5, which means it has the best power of growth in amongst all the embryos which formed. This should give us the highest pregnancy chances
Ma'am,
to a
what
woman.
cross-section of the society actually come forward for IVF, and what are the practical pricing that goes out in the market?
See, the women or the couples who need IVF is where it is indicated. It is indicated in women who have blocked tubes or who have tubes which are not functional. Say tubes which are absolutely stuck. They are open but they are so stuck that they don't have that movement that they can suck up an egg and transmit it to the... This happens in a disease called endometriosis, where it's a disease of the whole area which is surrounding the tube. It's the ovary, it is the pelvis. So everything gets stuck to each other. The ovaries get stuck to the uterus, the tubes get stuck to the ovary, the intestines come and get stuck to the uterus, ovary, tubes. Endometriosis is a disease which progresses with every menstruation. So it goes on increasing and increasing. Such are the cases which do best with IVF. If there are tubal blocks which cannot be repaired, do best with IVF. If there are sperm deficiencies which are like very low sperm count or no motility, or the head doesn't have a acrosomal cap, it doesn't have the power to penetrate an egg. I mean, there could be hundreds of millions of sperms, very good motility, yet the acrosome is missing.
Okay.
They also need IVF. We need to put
Implant.
the sperm, inject the sperm into the egg.
Right.
So these are direct indications of IVF. Blocked tubes, pelvic factor, and severe male factor cases. Then apart from this, women and men who have unexplained infertility, where we see there is no defect anywhere. They waited for years together, they've tried nth number of IUI cycles, but somehow a pregnancy is not happened. They also are another group which require IVF eventually as the final treatment for infertility. So these three are the major groups.
Right.
If we talk about own gametes
Yeah.
and own uteruses.
Ma'am, what kind of costs are incurred in IVF these days?
Generally in India, all IVF centers charge anywhere from 60,000 to about 1 lakh for routine IVF, which includes ICSI also. But then, there are a lot of hidden costs which a lot of centers don't advertise. Like if I say we charge 85,000 for IVF ICSI, that would include all ultrasounds which are done during IVF, for IVF, all blood tests which are done related to IVF, and the whole procedure of IVF till the pregnancy test.
Right.
There are centers advertised 25,000 mein IVF hota hai, where when you ask patients how much did you pay, they said, well, we paid about 1,85,000. And how was that when you went with 25,000? They said 25,000 was just IVF ka procedure, but then we had to pay for ultrasound separately, for hormones separately, for ICSI separately. And very surprisingly, I'll tell you that these fertility drugs are expensive. And if you see the MRP, then you know they are heavily costed. In one cycle, taking the MRP into consideration, you would use easily, a normal doctor would use drugs worth 70,000, 75,000. But we as infertility specialists, when we get these injections straight from these suppliers, the main company, we get them much cheaper. So we can give them in a much lower rate.
Right.
So, you know what happens if it's a package? They say, okay, we'll do all drugs inclusive. We're doing IVF in X amount of thing, and in which drugs will cost you about 70, and the rest is IVF. It's much better to say this is the cost of IVF and drugs as per actuals.
Right.
Go from the hospital chemist, and generally you will get a rebate on these drugs. I don't know how many centers give it, but we have subsidized our drugs, and our drugs don't go for more than 30,000 in a cycle, because we get them damn cheap. Damn cheap means almost 40% less. So even if you keep a margin of 20% for yourself, which you use because you've got personnel managing it, you've got to keep them in cryo storage, whatever you do, you can still dispense them at 20% less the MRP. If these drugs are bought from IVF center chemist or IVF centers directly. So it's much better to buy them as actuals rather than to go for packages where the drugs are included.
Right. Ma'am, are these covered under insurance?
Generally in our country, unfortunately not.
Okay. Ma'am, we touched on this subject of the emotional trauma and how people go through various phases of emotion in their attempt to parenthood. Ma'am, if you can touch on that, if you can highlight some...
Have you read a book, Baby Roulette?
No, I have not.
This is a book where a couple who went through IVF wrote a whole book on how it is like a game of roulette, where you know the wheel is spinning and you don't know where it is going to stop and what is your luck going to be.
So it is referring to the emotional turbulence.
Turbulence which goes through while this wheel is rotating, and you've put so much on stake in this wheel. So IVF is like that, because you know why? Once you're going through IUI, you still know IVF is there. If this doesn't work, never mind.
That's
we'll
a
try
backup.
3-4 cycles, then we'll go for IVF. But once IVF fails, then you don't know what to do. And it fails in one center once and twice, then you think I must go to another place. Then you go to another place and you find that we take out so much flaws which your IVF cycle had in the previous center, and you don't know whom to believe.
Right.
So it's so difficult to know who is really good. But I think what is very important is that you should be able to sit with the clinician, and when a cycle fails, it's very important to ask the clinician, can you also have a word with the embryologist sitting with you? Make sure that the embryologist is there in that center 24/7, so that he's fully responsible for the lab. The lab is the heart of IVF.
Right.
So it's very important to have a dialogue on failure with the clinician, with the embryologist, all of them sitting together, finding ways out that what is it which doesn't appear to have worked for you and what could make things better. So it's very good to have counselings done with the embryologist also sitting by the side of the clinician. And the embryologist must have a say.
Right.
In our country, we have very few centers where we've got qualified embryologists. We've got all embryologists who've learnt by, sort of training.
Right.
They are generally science background people who've done
Right.
MSc, BSc, or even technicians who have been trained to do IVF. So they do it like robots. They don't use their mind in it. We need proper qualified embryologists like the world has. See, today for Louis Brown, who got the Nobel Prize? Edward got it. He was the scientist behind the whole thing.
Right.
Steptoe didn't get, who was the gynecologist.
Right.
So the whole prize went to the person who did IVF, because the scientist is the main person behind IVF. It is not the gynecologist. We are doing the peripheral work, but the heart is pumping at the embryology site where the sperm and egg meets, and the embryologist has an eye to see which embryo is looking good, which is not looking good, looking at the growth rate. There the sixth sense works, because through experience our embryologists are working. But now, yes, we would have say maybe 10% as qualified embryologists in India, 90% are still just by training and experience that they do
So ma'am,
embryology.
we are touching on a very sensitive subject of capability by qualification and capability by experience. Is it an output of this demand supply rat race? Emotions demanding parenthood, I need a baby, and this is, the business side is also growing, and hence this kind of thing is happening.
This is true. You see, I think there is a feeling that IVF is very lucrative, whereas it is not lucrative. If we really try to practice IVF in its true form, then it is very taxing, it is very time consuming, and it has lot of insight that we need to do constant reading, and we need to keep upgrading our knowledge on every little score of IVF. And hence in embryology, what happened in our country was that we hardly to start with had 3, 4, 5 centers in major cities, and we really didn't have embryologists, but we had, like, our embryologist was a PhD from AIMS, and since there was no embryologist, we asked her, can you see a human egg? She said, well, I've worked on rat eggs, mouse eggs.
Okay.
So can you identify a human egg? Okay, identify one, read. And she started working, and we had our first IVF baby in northern India at our center only.
Right.
Now who completes 25 years this year, which we are celebrating. So I just want to tell you that that was our first embryologist. She was again not a qualified embryologist, but she was a PhD scientist.
Right.
Similarly, we have a lot of MScs and maybe less than that, more than that, PhDs who started taking up embryology as one thing, but then there was no way to read embryology. So they would just whatever read from journals and then start working on the microscope. Now there are a lot of embryology courses outside the country. Well, there are very good courses, Monash, National University of Singapore. In England, there are a lot of courses which have opened up. Monash is in Australia, which are for embryologists only, and we are getting batches of trained embryologists from there. Some places in India, like CMC Vellore, has opened up embryology training. And there are short embryology courses, which a lot of people are now opening because everything appears to be lucrative in the field of education. You know, for small trainings, big fee can be offered in these fields because these are specialized fields, and one really, has to work hard. But then we need lot of well qualified embryologists to be able to give us very good results.
Ma'am, you have been treating people, advising them for quite some time now. To a true sense, you are a veteran and you have seen a lot of emotions going in, especially when you're talking about parenthood. We're talking about not only a father or a mother, it's a whole society around them. So it's a whole ecosystem which works. So what a bit of advice do you give to people in terms of managing emotions in this ecosystem?
Managing emotions. Well, one is that I understand that parents are also very affected when their children do not have offspring. But one is undue pressure on girls the moment they get married. Sometimes I feel sad to see a 21-year-old coming to my clinic after 6 months of marriage. I have not got pregnant till now. So one is this pressure has to stop. Two is that everybody has to understand that if a girl is not being able to get pregnant, it could be the problem of a couple, and the girl should not be blamed. Two is that failure can always happen in this treatment, because success means we'll have to be God for that.
Right.
We cannot be God. Science has its own limitations. So we have to accept that yes, we will have failures, but failure doesn't mean that we've lost a loved one. We've only lost one chance of getting pregnant where we had put a lot of hopes. So very important to understand that only the chance has gone. We have not lost anyone. If you get pregnant and you lose the pregnancy, that's a bigger trauma.
Right.
And to lose someone who's already there, whom you've started loving by virtue of having seen that person, that is a very big trauma. But just having an IVF failure is not such a big trauma that the world gets shattered. Don't let it affect your interpersonal relationships. I think a husband and wife's relationship is far more important to be preserved or to be shattered on such a thing where you don't have a child or you have a child. So having a child is a desire of every couple, but not being able to have should not spoil interpersonal relationship between
Ma'am, over
a man
the
and
years,
woman.
obviously the scope of knowledge has grown. People are learning more about various subjects. Do you see a transformation
I see a transformation. I'll give you a very nice example. We celebrated IVF 10 years, then we celebrated 20 years, and now it's 25 years. At 10 years, we asked so many couples to come, even doctors from our own hospital. They said, no, we will not come because our family doesn't know this is IVF baby. I mean, we were like taken aback. A neonatologist refused to come. An anesthetist refused to come. Those who are there all the while seeing the agony of people giving anesthesia to my IVF patients. So this was the extent of inhibition in the heart or minds of parents, that the world should not know that this child is born through IVF. At 20 years it was less, and at 25 years it appears to me it's even less. A lot of people are asking, will there be any media? And we said, no, we are not having any media there. We are just having a gathering, you know, because it's 25 years and Silver Jubilee is something which is very important. So we've been pressurized by the management that you must do something. And that's why we're doing it. But that inhibition has gone down of saying that this child is born through IVF, or we have conceived this child through some treatment. It is still there. Today only one of my doctors called up one patient and she said, well, you know, we don't want to come because my family doesn't know. My family doesn't know that this child was born of IUI. And this is a patient who had 3 IVFs failed outside, had about 12 IUIs failed and conceived in the second IUI with us and went back with a child. And she said, no, we will not come because they don't know that we went through treatment for this child.
Right. But you see significant change, and that's
significant
the positive,
change. That's the positive thing. And a lot of men come forward with their subfertility, and they're very, very open to discuss it with their wives, that
right.
or with the families, to say that, you know, I have a problem and what can we do for it. And we are treating male infertility like nobody's business. Earlier we hardly used to do a TISA, PISA or a MISA. Now we are doing it every day. We do 3-4 cases of TISA because all men come forward when they know that they have a chance of fathering their own child.
Right.
They accept the treatment very, very happily, and the pregnancy rates are very good.
Ma'am, it is an extreme pleasure interacting with you. On behalf of my viewers, I would like to thank you for your time. I hope my viewers understand the complications and the implications of this emotional investment. They do a lot of research before they get into the journey of a parenthood. Thank you, ma'am.
You're welcome, and thank you for giving me a chance to speak my heart out.